And I hope I pronounce your name, Awori Hayanga. Is that correct? Is that close? Okay, pretty close, huh? So he's Associate Professor of Cardiothoracic Surgery at West Virginia University, is Director of the West Virginia University Heart and Cardiovascular Institute, an ECMO program. He is board certified in cardiothoracic surgery, general surgery, and surgical critical care. He completed his general surgery training at Johns Hopkins University at University of Michigan, followed by the cardiothoracic and transplant training at the University of Washington and University of Pittsburgh, respectively. He served as the Alfred Summer Scholar during his MPH at the Johns Hopkins School of Public Health in 2008 and the World Health Organization, WHO Patient Safety Scholar and Department of Health and Human Services, followed by a senior medical advisor to the Deputy Secretary of Washington, D.C. He holds a master's degree in business strategy from Massachusetts Institute of Technology. He is an expert association of Thoracic Surgery and services for the educational boards of the Journal of Thoracic and Cardiovascular Surgery and the Journal of Heart-Lung Transplantation. He has authored over 130 peer-review articles. I want to have a warm welcome for Dr. Hayanga. And there was multiple questions on the use of CytoSorb yesterday during our presentation. So hopefully you can address those questions and concerns at this time. Thank you very much, and thank you for being part of our meeting.
No, what an honor. Thank you for that generous welcome. And thank you for this invitation to be here today. I am going to share my screen and begin. Hopefully you can see that, Ty. Can you see that?
Yeah.
Great.
Yes, looks great.
So, you know, I won't go through the nuances of cannulation because this is a sophisticated audience well versed with ECMO, but we know that there are different configurations. We know that the history of this began in the 1970s, really, in terms of impacting the evidence-based literature, and we know the impact that Dr. Bartlett has had in such a tremendous way over the past 3 decades. Historically, we've evolved quite a bit, and from previously being dismissed as a hemodialyzer that wasn't quite up to speed, we really moved to becoming a mainstream rescue strategy. And this has been proven in the durability in the use of ECMO in post-cardiotomy support and also in neonatology, but certainly within the context of a pandemic, the H1N1 pandemic of 2008, the rigors of the CSAR trial in 2010 that cemented some of our thoughts and the protocols that surround ECMO and the impetus to increase the technology, the investment in technology, the investment in expertise that has resulted in really a ubiquitous approach to ECMO across the globe. Now here in West Virginia, we are a quaternary referral program. We evolved from being an entity that supported post-cardiotomy to support patients after open heart surgery to one that catered to ARDS, influenza, as we have seen a rising number of cases come from lung failure in the past 16 months. And this is true here as well. But true to our contextual existence, this is ground zero for the opioid epidemic. We see a lot of these cases, and we are a coal mining population, but we also have aspirations in the arena of transplantation. So to support our heart transplant recipients and for our emerging lung transplantation aspirations. We are a rescue strategy. We are a program that has evolved from the alliances of a multidisciplinary stakeholder group that involves perfusionists, pulmonologists, cardiologists, anesthesiologists, hematologists, nursing staff, respiratory staff, occupational therapy, physical therapy, nutrition. We are based on an evidence platform, and we train our ECMO specialists from a cadre of registered nurses and RTs. And from this, we have cultivated our homegrown bedside team. We went live in 2018. Initially, we were perfusion-led, and we transitioned to a nursing-led program because that is where we draw our ECMO specialists. Since our inception and over the past two and a half years, we have done 200 cases, 50,000 hours. We cover our CICU, MICU, the CVICU, the ED, the cath lab, surgical floors, the rest of the state, and indeed the region, which is Appalachian in origin and context. We really embrace high quality research that can allow us to educate. We perform an outreach to support the counties in our state, and we welcome innovation. Everything is done through a public health lens. We have an EC-145 helicopter, actually 2 of them, and this is what we use to service the hub and spoke model that really characterizes our program. When we originally started, we were perfusion-led. Now here, I'm just going to slow it down a little bit to explain to you how we changed our cost structure, because a lot of what we discuss in ECMO is influenced by how much things cost. The dotted line here are costs that pertain to perfusionists at the bedside. The solid line is where you have nursing-led specialists at the bedside. Red is a low volume program. Green is mid volume, and blue is high volume. And what we found was that if you're a low volume program, it doesn't matter how you staff your ECMO patients at the bedside because the costs are pretty similar. But they begin to dichotomize and diverge pretty dramatically with an increased volume. And if you're a high volume program, there's a significant difference in cost, millions of dollars in difference in how you staff your program. And so really it's predicated on volume and capacity and utilization. We cover many counties. We use air to do this. And now going back to what we have described in terms of cost, revenue, and the fiscal aspect of ECMO programs, here, the gray line that goes right across from the convergence of the axes and straight up diagonally is revenue. The blue line is fixed costs, what you pay, your pumps, your buildings, electricity, the cost that you pay no matter what happens, whether you have 1 patient or 30 patients. And then disposables and variable costs here in orange. And so essentially, when your revenue can cover your fixed costs and your total costs, that's the break-even point. And the gradient thereafter, revenue is your contribution margin. But here, what we are trying to depict is that there is a break-even point at a utilization of about 10 cases a year, beyond which we proved that it is more profitable to invest in teaching your nursing staff about how to manage the ECMO patient at the bedside. And this is up for publication later on this year. ECMO volume has been growing dramatically across the globe, not just in the United States. And we've seen the same thing here in WVU. Our numbers increase by 55% every year. Now, the patients that we support have changed in quality, in quantity, in context, really. We started off as mainly a post-cardiotomy support program, mainly patients who had failed to come off cardiopulmonary bypass. But whether it is the epidemiology of viral illnesses or something that has happened across the region over the past 2 years, we've moved to seeing a lot of patients who are in lung failure, be it for ARDS, septic shock, bacterial, pneumonia, and most recently, of course, the viral pandemic in which we're currently embroiled. So we've moved to becoming almost 57% VV ECMO. And this is true too, when you look at the ELSO numbers, more cases now are a result of pulmonary failure as opposed to cardiac failure. Now, when we look at outcomes, and outcomes are important because those are benchmarks by which programs are measured. For lung failure in 2019, it was necessary that you get up to 60 to 70% survival. For cardiac failure, 45 to 55%, and ECPR, 30 to 40%. These are benchmarks, and these are the numbers that we use to set our goals. Now, what we found over the course of the past 18 months is that by benchmark, survival to decannulation by ELSO, 62%, we were achieving 92%. Survival to discharge by ELSO is 49%, we were achieving 87%. This was true even using the lens of risk adjustment. So SAVE score for VA ECMO and RESP score for VV ECMO, we found that our expected survival was 30%. Our expected survival in VV ECMO was 57%, but we were getting 84% and 93% respectively. Giving you context here, at the start of the COVID-19 pandemic, the CDC declared that West Virginia would have the highest carnage, the highest number of deaths, the highest mortality from this illness. So these are values that one needs to take into context of the population that we serve. Looking at the various risk adjustment scores, we have just as sick, if not sicker, in terms of clinical severity in patients that are placed on ECMO compared to everywhere else in the country. And it was important that when we transitioned from a perfusion-led model to a nursing-led model, that we did not lose ground in terms of our outcomes. And our survival probability didn't change. We were achieving the same results. In fact, the results became robust enough that we were trusted with equipment and new technology, and we had so many trials going on that we no longer needed to rent any equipment. And this in turn actually translated into a cost saving because we had no reason to have a redundancy in equipment. So coming into the beginning of the pandemic, we had in place a quite a robust structure, and we had, through the course of 2 years, gained confidence and a sense of positive multi-stakeholder cohesion to begin to address COVID-19. Now, of course, COVID-19 is not only about ECMO. And so we found that within the state, public health initiatives such as mask wearing, hand washing, social distancing made a difference. So in this graph, each dot is a day in the week. And these are presentations to the ED with viral illnesses. So when you see, you go Monday, Tuesday, Wednesday, Thursday, Friday, it drops down Saturday and Sunday. Saturday and Sunday, people don't like to come to the ED with viral illnesses, but it spikes up again on Monday. So this was the trend that was going on at the beginning of 2020. And then the governor instituted public mask wearing in mid-March, and it dramatically took effect. And the numbers of patients presenting actually decreased dramatically, proving that public health initiatives work. But from an ECMO standpoint, we were seeing consults, every patient we placed on ECMO, we probably saw 1 or 2. We have a capacity of 6 to 8 patients. And so once we got to 8, we could no longer service that patient with ECMO. The patient either had to be transferred or we had to decline them, one of the two. But essentially, at the beginning of the pandemic, for every 1 patient we placed on ECMO, we saw about 2. During the second surge, around the summertime of 2020, those numbers started to go up. And here, the red graphs represents outside hospital consults, whereas the blue are the consults that we get from within the hospital. Really, those increased, but not so much. What really increased were the number of cases we were getting from outside. And we went beyond our state borders. We were getting consults from Ohio, Maryland, Virginia, and Pennsylvania. And these numbers started to go up around the summertime. July to August, we were seeing 3 patients for every 1 that we would place on ECMO. By the time we got to later October, early November, we were seeing about 8 to 10 that we were placing on ECMO. 8 to 1. We'd see about 8 to 10 patients before we placed 1 on ECMO. And by the time the end of the year came around, we were seeing almost 30 patients for every 1 that we would place on ECMO. Another dramatic change that happened was that the median age of our consultations and patients placed on ECMO was going down. Initially, we had started off in the 50s, but it quickly went down into the mid-40s. But patients were also sicker. So based on Apache scores and SOFA scores, these patients were sicker than they had been in previous years. And what we were seeing here was very similar to what was going on around the US. There was definitely a surge going on, and a devastating surge around December going into January 2021. When we look at Medicare data, these excess cases that resulted in mortality were reflected in ECMO deaths even before the pandemic was declared. So here, this black line is baseline, and anything to the left-hand side of the screen is a decrease in ECMO mortality in 2020 versus 2019. And anything on the right-hand side of the screen is an increase in ECMO mortality in 2020 versus 2019. So if you're on the right side of the screen, that means that in 2020, you saw many more deaths than you had in 2019. And if you're on the left-hand side of the screen, then you saw much fewer deaths compared to what you had seen in 2019. This is before the pandemic. This is the first quarter of 2020. This is how you can tell that something was going on in the United States before WHO declared this pandemic. And New York was hard hit. They were seeing 20-25% increased deaths on ECMO than they had in 2019. Another point to prove that data can tell us a story long before our emotions accept the facts. This was true also when you look at trends across states and regions. Here, this is the number of influenza-like illnesses that were being reported when you compare 2011 to 2021. And here the green, the area under the curve, the green for 2020 was dramatically different. The number of illnesses was dramatically higher than anything that had been seen for a decade. And what we were seeing of these lungs, it was horrific. These lungs were very rapidly looking very, very bad. The compliance, the atelectasis, the barotraumatic effects were much more evident, much faster in these lungs than they were in anything that we'd seen prior to 2020. In the state, there were a number of things that had to be put in place in order to mitigate what the CDC had anticipated to be abject carnage in West Virginia. The governor very wisely selected our dean, a pulmonologist, as the coronavirus czar. A number of us were called to assist in giving advice to the HHS in DC and to help to state what we thought would be the priorities in developing a rescue strategy, a safety net when conventional therapies had failed. These are the discussions that I think prompted the fast tracking of some of the FDA approval of some of the devices and oxygenators that were approved in 2020. West Virginia took the lead in identifying populations at risk, such as those in nursing homes, and was the first state to vaccinate all nursing home residents. And we were beginning to see that even though we were predicted to have the highest number of deaths during this pandemic, we were managing to keep our patients as safe as we could. And from an ECMO standpoint, they were surviving more than anticipated. Now, we clearly had to adapt to a triage, global pandemic frame of mind. We were no longer going to delve in ECMO in the age 65 plus range. We had to be more conservative. We had to drop that age down. We had to say, look, there are some comorbidities that we cannot risk taking. We have to assume that the patient has no end organ damage from anything else apart from the lungs affected by COVID-19, because otherwise we would delve into futility. The body mass index debate had to be really front and center, because there are some BMIs above which it is very difficult to achieve adequate perfusion. And this is a limitation that we had to accept upfront. We had to look into the history in terms of smoking. If they had a cardiac arrest prior to cannulation, they were no longer a candidate. If they arrested as we prepped, they were no longer a candidate. We modified Eolia criteria such that it wasn't sufficient to say that they were mechanically ventilated for less than 7 days. We insisted that it should be less than 4 days. Indeed, during the second surge, we dropped that down to 3 days. And we accepted that there was a cytokine storm going on. And this is something that seemed controversial to some groups, but not controversial to us, because when we measure D-dimer, CRP, ferritin, these numbers were off the charts. And we figured that that has to be part of how the spike protein initiates and perpetuates damage within the cellular environment. And so to us, it seemed a logical extension of the ECMO protocol to add to that a way to mitigate the effect of this cytokine storm, to decrease the number of cytokine inflammatory markers that were circulating in the body. Now, all this had to be done in the context of ensuring that what we were doing was going to translate into saving the patient and ensuring that our outcomes didn't change. Now, we were already under scrutiny for having moved from a perfusion-led model to a nursing-led model. And so we had to ensure that the survival didn't change. And so it hadn't changed when we looked at our entire numbers before and after August 2019, when we made the transition. But now we had this situation whereby we had this pandemic, and we wanted to make sure that our outcomes, which had been 2 standard deviations above ELSO, remained the same or as close to that as possible when dealing with COVID-19. And when we looked at all of these numbers, after a year of treating COVID patients, our outcomes are the same for COVID-19 and ARDS from any other source, be it influenza A, H3N2, influenza A, H1N1, bacterial, or any other viral pneumonia. This is true for survival to decannulation, survival in general, time to tracheostomy, time to extubation. True too for time spent on the ventilator, time to extubation as previously described. And everyone asks, well, what are you doing differently? What are you doing differently that your outcomes haven't changed? Because the initial sentiment had been that in China, Italy, and New York, ECMO didn't look like it was working for that first surge. And then a second series of publications came out saying that the results were respectable, but no one really was reporting or has reported outcomes that were better than ELSO. And then ELSO was also getting all these reports from different centers that were seeing a high level of carnage. So the ELSO benchmark also started to fall. So the question was, how can we deal with COVID-19 and maintain respectable survival rates? So we looked to a number of different things. And one of the differences in what we do is now the routine use of a cytoadsorption technique. Now, we use CytoSorb often, and it's built into the circuit before we put the patient on ECMO when they have COVID-19, and we start the 72 hours at the onset of perfusion with the extracorporeal support with the CytoSorb in line. Now, this is solid state chemistry, no ligands, antibodies, biologics. The cytokines are removed, pore capture, adsorption. The surface is vast. It is a means by which you can capture a lot of these cytokines and stop their cycle of carnage within the system. This was new because previously we had used plasmapheresis, and even then that was controversial. A lot of centers who we coach had said to us, we don't understand how this should work. But we demonstrated objectively by first having a protocol whereby ferritin greater than 1,000, D-dimer greater than 3,000 is an indication for us to use a cytoadsorption technique. CytoSorb came out and was released on an emergency use authorization by the FDA. So we could only use it for 72 hours and only in COVID-19 patients. But we had previously experimented with plasmapheresis and septic shock and had seen very pleasant results. CytoSorb was achieving the same thing. We were able to get the ferritin, D-dimer, and CRP levels low in both these techniques. And there was something about it that allowed us to support the patient in a more stable environment. Their numbers in terms of the hyperdynamicity, the lability correlated with lower levels of ferritin and D-dimer and CRP. And so if there was a way that we could calm down this inflammatory storm, the patient seemed to do better. We were using both of these where we had to. That CytoSorb could only be used for 72 hours, but we could use plasmapheresis whenever there was a raging cytokine storm, as evidenced by the serological numbers. And so our center, always preoccupied with how much things cost, posed the question, well, is there a price difference? And what are we spending to get this result? If we're saying that this is a vital and necessary part of the armamentarium against COVID-19. And what we found was that we were using $9,000 for a case that had 6 filters. And what we found was that for one patient, really averaged over the 4-day treatment, the total amount that we were paying was $6,000. The administrators thought this was a lot of money. They said, now we are spending this per patient. How does this compare to our previous practice of just using plasmapheresis? So we went back and we looked at plasmapheresis, something we hadn't done before. And we found that the treatment cost $1,300, the tubing cost $300. whether or not you used FFP or albumin had a huge difference, and FFP was much more expensive. And that had been the provider's preference in the ICU, was to use FFP. And then there was staffing. You had to bring in a nurse to cater to that plasmapheresis over the course of the night. And so when we looked at it, we found that plasmapheresis for 5 days cost $16,000 if we used FFP. And if we used albumin, then it was $10,000. So to our surprise, it was much more expensive to use plasmapheresis than to use CytoSorb. And we ended up winning that argument. But fundamentally, what we wanted to explain to other centers when they asked us, what are you doing differently? Everyone was doing a modified EOLAIR criteria. A lot of places had cut down on the BMI and cut down on the days of mechanical ventilation. But we were making the point that when you look at ELSA in the context of this pandemic, the in-hospital death is 48%. That's 50%. Half the patients are dying on ECMO. And these are centers that report their results. Remember, there are ECMO programs out there that do not report the results. So this is what is the best out there, because people tend to tell you good news and hold back on the bad news. The in-hospital death is 48% in ELSA. Our in-hospital death is 16%. That's 3 times less. And so it was compelling to our administrators that we were achieving numbers that were 3 standard deviations lower in terms of mortality and 2.5 standard deviations higher in terms of survival. And this is true too now across the board, because ELSO numbers have now been affected by the pandemic. So when we look at our survival to discharge, it's 72%. Survival to discharge in ELSO at best is 59%. And these are screenshots from ELSO. These are not derived numbers or interpretations. And these are the facts that we present. Why is this important? Because we are a state that was predicted to have the highest carnage from the virus. Now, a lot of this is contextual. So, for example, the vaccination effort in West Virginia is one of the most unparalleled in the country. In March, if you listed every country and every state as a single entity, then West Virginia was second only to Israel in the world for its vaccination effort. So there's some special factors, yes, that have to be taken into consideration, because if a greater number of people are vaccinated, it helps. You're not yet at herd immunity, but it helps. So legally, West Virginia doesn't tolerate exemptions of a philosophical nature. That isn't something that is tolerated from a public health standpoint. So there's a vaccination acceptance about the utility from a public health standpoint. Now, philosophically, the West Virginia administration wasn't willing to say, let the federal government do everything for us. They said, let's take this responsibility as a state. And let's take this responsibility as a community. And so instead of relying on one Walgreens to help vaccinate 250 nursing homes, they took it to the community and the community pharmacy and said to them, you're responsible for these 17 nursing homes. And in order to maintain their responsibility, ethical and otherwise, to the residents of that nursing home, those pharmacies went and implemented aggressive vaccination campaigns that CVS and Walgreens just wouldn't have the bandwidth to do. The National Guard was implemented in storage and distribution. And the leadership, again, was at the hands of a physician who studies bad lungs as a specialty. There are very few states that don't tolerate exemptions. West Virginia is one of them, as specified before. And then it was one of the first states to make sure that 80% of the population had access to that first shot. And so here, the darker the state, the increased percentage of population who received that first vaccine. And so was true for the second shot in terms of a fully vaccinated population. West Virginia was pushing fast and hard to get those numbers across. Again, we were the first state to vaccinate all nursing home residents, and this was done early in November 2020, long before it had become a federal government priority. We've been involved in addressing vaccine hesitancy and vaccine equity at the administrative level with the Health Secretary of Health and the governor's office and a health commissioner. And when we look at all the events that have fallen into place to allow our ECMO population to do well, there are a number of different things that are clinical, but they're also administrative, and some are even political. It is the contextual description about how these things have happened in order that we can address how reproducible they can be in a different region. And it's important because ECMO is expensive. $20,000 a day, every hospitalization that involves ECMO increases by anything between 20 and 40%. Length of stay typically doubles. I mean, the question is, who will keep paying for all of this? And is it cost effective? So we have a very straightforward policy. We cannulate, extubate, and ambulate. And that's the ethos that drives the management. So typically, yes, when able, we prefer to perform VV ECMO using a single cannula so that, yes, we can insert it in the right IJ and direct it down into the IVC so that we can then use the pump to direct this oxygenated blood directly to the tricuspid valve and perfuse in this way such that the patient has only one site and can walk and is free of being tethered to the bed. Now, this involves going to the OR. We typically use a combination of TEE and fluoroscopy, and it's very effective. But in the context of COVID-19, we wanted to limit exposure. In March and April, we didn't know what we were dealing with. We didn't know whether or not there was going to be a vaccine or treatment. Everyone was just getting convalescent plasma. So we restricted everything to the CVICU. We kept everything within a single area so that we wouldn't have to expose staff to this virus. But still, our policies haven't changed. We prefer to cannulate, extubate, and ambulate. And that continues to be our philosophy. We are data-driven. So it is compelling to us that the use of a cytoadsorption technique coupled with ECMO, when looking at how we manage things differently from other hospitals, is something that we think bears a lot of promise. And it is, we have continually added to the literature. And in the last Society of Thoracic Surgeons meeting, we held a webinar in which literally we were just fielding questions from other ECMO programs about how we do things, why we use bivalirudin versus heparin, when we use heparin, why we use CytoSorb, when we use plasmapheresis. And we end up coaching a lot of programs. We're coaching up to 11 right now. We do a lot of simulation. We have a simulation center, mannequins. We're constantly teaching. And it is really because of perhaps thinking outside the box and being accepting of new technology that we have dedicated these resources, the time of our providers, to treating these patients, to taking them and bringing them back into the hands of the people that they love, the homes that they know, and the lives that they lead. Here, one of our specialists has woven our patient's hair to hold her tubing and a cannula. It's a personal touch. It's something that they spend a lot of time together encouraging each other. The TLC aspect of the technical things that we do, essentially the quadruple aim incarnate, where you address outcomes, clinical experience, patient experience, and lower the costs overall. Thank you very much for this opportunity. I would like to hand it back to our gracious panel.
Thank you for your wonderful presentation. Due to time restraints, we're very limited as far as the questions. Maybe we can take one or two. Someone want to basically bring up some of the questions from our audience, and we need to keep these short and simple, please.
Yeah, I'd be glad to take the first one. Thank
Carla,
you. Thank you for an amazing talk today. Really a lot of information and great work in West Virginia. I get over to Pikeville once in a while to take a look at their ECMO program with Dr. Io down there, but you certainly have shown some terrific results. We have so many questions for you, but since we don't have much time, I wanted to break into the CytoSorb usage. Yesterday we had 2 reports and possibly a paper that's coming out new that possibly the cytokine absorber was taking out too many cytokines and risking the patients to systemic infection. This was new to me. I've seen the beneficiality of the CytoSorb in certain patients, but I'd love you to comment on that, sir.
That's a great question. And it really would be very difficult to prove because superinfections can occur with or without the cytoadsorption. And I think that one way that one could look at that is to see if you achieved cytoadsorption in an equivalent model. So for example, with plasmapheresis, would that patient also be susceptible to infection? And then secondly, would it be possible to prove that patients who were on ECMO without cytoadsorption would not get the infections that were listed by the antagonists of the CytoSorb model? I think it's difficult to prove because essentially it is a question about increasing the immunosuppression of CytoSorb. And I think that it's going to be difficult to prove because we certainly haven't seen it. But again, there's so much confounding that we could possibly be questioned about maybe not having had 100,000 patients on CytoSorb and therefore not having sufficient power to detect that occurrence of increased infection. It's a difficult one to prove, but it's a good discussion point.
Let me just add one thing that I believe heparin, Ty, I believe that heparin has to be used rather than DTIs with the CytoSorb. I want to make that point.
Yeah.
That is correct.
We're going to have to break to our break right now. I'm sorry. If you have a contact that we can share so that people that have questions,
yes.
I know y'all don't have a booth. Wish y'all had a virtual booth today that more questions could be asked. So we're going to take, and thank you very much for your excellent presentation. Sorry we ran out of time.